when you are approximating on the level of L4, you go a little bit up or down to this, and you insert your needle, you puncture. Of course, you have to disinfect the area, and then you go in for the lumbar puncture or spinal tap. Now, this has, of course, a lip, an outer lip, and an inner lip as well. And anteriorly, it is actually surrounded or ends or begins actually here by anterior superior iliac spine and posteriorly posterior superior iliac spine. And you have here another counterpart for this anterior inferior iliac spine and posterior inferior iliac spine. So there are 4 iliac spines, and these are important to know, especially the anterior superior iliac spine, and has again some anatomical and clinical significance that will come back to this point. So it's good to know these bony points, and whatever I actually mentioned would be really some good questions in the lab as well. The iliac crest is used in practice for bone marrow extraction. We actually, especially we have the patient lying down, prone on the abdomen, and we anesthetize this area, disinfect and anesthetize, and then we go with a needle which is a little bit thicker perhaps. We get into the bone, and then we screw it a little bit. It's harsh sometimes, especially the nurses, they do that. So not only the doctors, and even in other countries, nurses do that. You puncture it, and when it is punctured, you feel that you went into a hollow space. So it's not, you don't see the resistance, you don't feel the resistance. And then you are in the place. Then you insert the syringe and you aspirate. The fluid, this is like blood, but a little bit more viscous. So the viscosity is a little bit more, and then you bring it up. You may need the needle for some time if you need it, if you need more. And then you can put this blood or bone marrow on the slide, glass slide, and then you do the staining on the material. So we do this actually in people who are suffering from leukemia. People who are suffering from leukemias, various types of leukemias, for example, monocytic type or other types, then different blood cells are not functioning very well. And we have blast cells in these patients. Blast cells are immature cells. And these immature cells are released into the circulation and they cannot function well. So these patients with leukemias, they have white blood cells that they are not really functional. So they are really prone to infections, as well as platelets that cannot stop bleeding. So these people may have bleeding, and if bleeding starts, it may not actually stop. Or even less oxygenation. The red blood cells may not be mature and ready. So these are various types of leukemias, lymphocytic leukemia or other type of leukemias, blast cells. Now, in these patients, then we actually get the bone marrow almost every day sometimes when we treat these patients. Then we have to see the effect of the treatment every day. Sometimes even 2 times a day, sometimes you may need to go and extract the bone marrow and again do the cytology and look at the cells, count the cells, and to see if the treatment is working. The same way we extract this bone marrow and then we inject it into the vessels of the same person or another person if they match. The blood type and the cell types, they match. That is called bone marrow transplantation. So bone marrow transplantation is taking the bone marrow from here. This is one of the sites, and then inject it actually into the vessels. Sometimes we take it from the same patient after the treatment when we see that the blast cells are now gone and the person has recovered, we actually remove some of the bone marrow and we reserve it for future if the disease comes back. Then we can actually transplant again the bone marrow to the same patient. Or it can be from a relative or somebody, for example, blood type and other things. Good, so this was one. The other place that we take the bone marrow is the sternum. The sternum is here, and that when we come to the sternum, we will discuss that. That is a little bit more, should be more careful and cautious because of some important structures which are there, and we will discuss that later on. Okay, this part is also sometimes used for bone transplantation as well, because it has a very good blood supply, and you see in the adult actually we have the red bone marrow here, so it is a very active part, and we can actually use it for bone transplantation as well. However, nowadays we have a lot of techniques now, and we are actually making a lot of cells outside in the lab and then transplant. Okay. Now the lateral or posterior aspect of it, just beneath the iliac crest, we have three lines. These are called the gluteal line. This is inferior, and this is the anterior, and this is posterior gluteal line. So inferior one is really inferior. This is anterior and posterior gluteal line. And these gluteal lines actually are the site, or the spaces between these, or posterior to these, are the sites for the origin of the gluteal muscles. So we have the gluteus maximus, which is basically originating from here posterior to this posterior gluteal line, as well as iliac crest and this superior posterior iliac spine and some other places, and then gluteus medius from here mainly, and gluteus minimus mainly from here, this area. So we'll see those gluteal muscles. Now coming down a little bit posteriorly, we have a sciatic notch. This is the greater sciatic notch, and this is the lesser sciatic notch. And in between them we have the ischial spine. So you see now we come to the transition. Now the ischium is here. So this is called ischial spine, and this is ischial tuberosity. This is the body of the ischium, and this is the ramus of the ischium. The ischial tuberosity, you are actually sitting on your ischial tuberosity. So when you sit on the ground, actually mainly, you sit on the ischial tuberosity. Especially the thin people, the slim people, one can even touch the gluteal, the ischial tuberosity. Ischial spine is very important for us, as I said, clinically. Then when we come towards the end of this course, I will discuss about the ischial spine and its clinical significance during anesthesia. Now, greater sciatic foramen, notch, and lesser sciatic notch. Now, these notches actually become a foramen when they are covered by two ligaments, and these ligaments are the sacrotuberous and sacrospinous ligaments. So these two ligaments are called sacrotuberous, so from the sacrum to the ischial tuberosity, and sacrospinous ligament. And they form now, this is the greater sciatic notch, now is converted to greater sciatic foramen. And this is the lesser sciatic foramen. So these are important. This picture actually will be in the exam. In the first exam, I will give you this picture. I want you to know the ligaments and the spaces which are in this picture, and I will be discussing this today as well. Okay? So the same picture will be in the exam, but I want you to know beyond what is this and what is that. By the way, when I tell you this picture will be in the exam, this picture will be in the exam, and no hesitation. I told you that I tell you the question. But I want you to know a little bit more about that, and that little more I still discussing here as well. For example, And there are some